EMS Forum. As we know, COVID-19 has impacted the world in a negative way. Our resilience as a region, as a nation, as a people is dependent on our preparedness. And as we, those in the EMS and the emergency response agencies, whether you're a doctor, EMS, fire officer, doesn't matter where you are, how we come out of this is how we're dependent on how we respond to it at this time. CAFC, the Caribbean Association of Fire Chiefs, for those who don't know, has, and this is the second of such a forum that we've conducted. The first one, we will discuss some of the provisions among the fire chiefs and what they did. And some of our members, the special mention goes to Chief Smith and Chief Warren, Chief Dr. Bayer, Dr. Warren and Dr. Bayer, who felt that it was important to have a forum that you can specifically discuss areas of the EMS. And we felt it was a very good initiative, and therefore it was approved by the executive of the Caribbean Association of Fire Chiefs, and we are here. But more important is the fact that after COVID, we have to survive. During COVID, we have to survive. And once we can share our experiences throughout the region and strengthen each other, our ability to come out of this a more resilient nation, stronger persons, and most importantly, alive, we have to share what we know and what we have done and our experiences in order to strengthen each other as a region. So tonight, I really commend the team of officers on the panel that we will have, some distinguished gentlemen. Most of them are from either fire and rescue services or the EMS service. And they will share with you some of the things that that has been done in the region in the various departments, what can be done. You will have presentations from a number of them. And also you will be able to take or to field questions. They will field questions from you to see if we can even put a better program in place. What I want to say to you also, and you can share this, the Caribbean Association of Fire Chiefs has just put a committee together headed by Dr. Bayer to look at CAFC COVID operational group. It's a CAFC COVID operational group. And looking at guidelines that whether we're EMTs or firefighters, how we can best put measures in place and protocols in place to, that if we have to respond to a visiting a nation that have been impacted, how we will do that. And also do a publication, COVID guidelines under the letterhead of CAFC, of how best we should prepare ourselves in the region. And bearing in mind that we might not have necessarily have all the resources that persons in the more metropolitan cities will have. So without further ado, I want to introduce the moderator for this evening. That person is no other person than Dr. Winston Warren. He is the EMS professor with the Daytona State College. He is a Barbadian by birth. He was loaned to the United States for a short while, but I'm sure at some point he will return to Barbados. And you will recognize that he's a Barbadian because how fluent he can speak Bajan. And as he goes through this, we ask you to give him your full support. And without further ado, Dr. Warren, the
Thank you, Chief Manor. Thank you, Chief Manor, for those warm words. A colleague of mine accuses me of not being from Barbados, and we will not mention Dr. Smith as the culprit. So I'd like to welcome all of our friends and colleagues from the Caribbean, welcome all physicians, nurses, paramedics, EMTs, firefighters, and all of our healthcare providers who are putting themselves on the line day in and day out, trying to perform an excellent job of providing pre-hospital care. I am, as Chief Maynard said, a professor of EMS. I've been in EMS for about 30 years. I've had the fortunate opportunity to serve in various roles, including preceptor, field training officer, supervisor, and my last assignment in EMS was area operations manager. And from there, I got into education, where I'm in charge of a paramedic cohort, and I also oversee our EMT program, which is about 70 to 80 students per semester, plus my own teaching class, which is another 25 to 30 students. So you can see I'm a little bit busy. This evening, the focus will be, as we stated, about what's the coronavirus as it relates to the Caribbean. How are things working in the Caribbean? We'll discuss best practices and basically have a great and healthy discussion. The panel we have is a very diverse panel, and I'm fortunate to be a part of the Caribbean Association of Fire Chiefs. My role in the Caribbean Association of Fire Chiefs is the chair of EMS programs, which involves aligning all the education and training. Dr. Smith will expand on our role and our goals of the KFC. I would like to start off by introducing our panel, and we will start with Dr. David Beyer. He's the physician that oversees and provides medical oversight for the Barbados Ambulance Service. Dr. Beyer. Dr. Beyer.
Yeah, go ahead. Say something. Good evening, everybody. I thought you were just going through the roll call and then we get to it. So good evening to everybody. Happy to be here. Looking forward to a really good session with you.
Excellent. Next is our CFO, Joseph Dupree from Dominica Fire Service. Chief Dupree.
Good evening, all. Just came from a telephone call here, and I'm driving home. I'm not sitting as comfortably as my president, Chief Maynard, or the many on the esteemed panel. I just want to indicate that it is truly a pleasure for me to be able to participate in this forum. As Chief Maynard indicated, we are dealing with something that is at least unprecedented for us, at least for the last 100 years. And I know, though, that we, the frontline workers, as we have indicated already, if we do our part as we are, in fact, it will make a difference in the lives of those that we come in contact with. The name is Josiah Dupuy. I'm the fire chief of the Commonwealth of Dominica Fire and Ambulance Services Division. Have been fire chief for the past, I need to count that now because it's been so many years now. At least sitting in the office for the last 14 years. And also for the same period, I have been the reluctant treasurer of the Caribbean Association of Fire Chiefs. I think I better stop here now because again, this is such an esteemed panel that I consider it just a privilege to be here, and I'm pretty much going to be listening and learning. So, Mr. Moderator, I pass it back to you.
Thank you, Chief Dupuy. I would like to move to Captain Will Hall, Miami-Dade Fire.
Good evening, all. This is Will Hall from Miami-Dade Fire Rescue, also professor of EMS for Miami-Dade College. I'm part of a group of infection control officers that are responsible for exposures, disease prevention as it relates to infection control. Happy to be here. Back over to you, moderator.
Kevin Hall, Deputy Commissioner, Aunton.
Thank you, Mr. Moderator. I'm Kevin Horton, Deputy Commissioner in charge of operations for the Jamaica Fire Brigade. I'm happy to share our experience with everyone and also to learn in the same breath. I would like to also acknowledge my superintendent who is in charge of EMS here in the Jamaica Fire Brigade, Superintendent Gary Morgan, who is also a part of this discussion. I'm happy to be here. Thank you very much.
And I'm Dr. Hezadine Smith, EMS Operations Chief, Orlando Fire Department, also responsible for information and technology as it relates to our operational framework and also our communications center. I'm involved with that. 32 years of experience in emergency services, and I'm happy to be here. Original Yadman from Montego Bay, really born and lucid. So welcome and thank you for being here this evening. He's muted.
That would be Dr. Flores and Ms. Doreen Gumps, and also our Chief Richards.
Dr. Flores.
So,
hey, hello everybody. Gustavo Flores from Puerto Rico. I'm a physician, a general practitioner, and I've been a paramedic for 20 years. I also run a training center in Puerto Rico, also faculty for American Heart Association and the National Association of EMTs. And glad to be able to help any of you in anything you need.
thank you, Dr. Flores. Ms. Gums?
Good evening. Can anyone hear me?
Yes.
Okay, thank you. Okay. It's Doreen Gumsvine, and originally from St. Martin on the French side, and I was invited into the CAPC at the time when they were integrating fire officers to be trained as EMT. I have a history of having been done that DC Fire EMS, former Chief EMS Training Officer. And because of my roots in the Caribbean, my goal was to always help and to give back. And up from 92 up until now, we've been engaged with EMS from the hospital level, the EMS level, and the local level. And I'm glad to be here tonight.
Thank you for being here. Chief Richards, if you can be so kind. Chief Richards? There you are. Nope, that's not him.
I'm on the road, but I'm really pleased to see this forum going forward. I did pull off to make sure that I could join. I think it's a very important forum with the current challenges in the Caribbean. I think it would be really, really wonderful. Come on. My little man is here with me. You understand? Wait.
We thank you for joining, Chief. Thank you.
Thank you, Chief. I'd like to thank everyone, and I'll ask Dr. Hezadine Smith to do an overview of the Caribbean Association of Fire Chiefs Emergency Services Registry overview.
All right, so actually, interestingly, one of the questions that came across was, what's the purpose of this initiative? And I thought it'd be appropriate to actually share a little bit about our efforts regarding EMS pre-hospital care in the Caribbean, across the Caribbean, and our efforts within the CAFC. So I'll take a moment here to, can everyone see my screen? If you can see my screen, I think you could probably put a thumbs up or something. All right.
Mm-hmm.
Stand by.
Yes.
Sometimes when you're full screen, you can't see it. Somebody's trying to get in the room. I'm trying to do three things at once. But as indicated, the Caribbean Emergency Service Advisory Council was established as a body within CAFC and authorized to conduct and provide recommendations regarding practices and policies. So I'm going to provide you an overview about our efforts across the Caribbean and our framework. As we mentioned before, Dr. Bayer, he's been very instrumental in establishing relationships, not only in Barbados, but certainly across the entire Caribbean, because he's a recognized lecturer, physician, practicing physician, researcher, and you name it, he's the man, and he's actually known in the United States as well. So I thought it was fitting that his contribution as a medical advisor be taken, is offered to assist us to just take advantage of that opportunity. You know, I'm Hezedine Smith. I've indicated already, I'm a paramedic, been around for a little while. Also professor at Columbia Southern University, Embry-Riddle Aeronautical University Business Management Programs, and I spent about 15 years teaching in the paramedic program, focusing on simulation in the paramedic lab for Valencia College here in Orlando. Dr. Warren, we spoke about Dr. Warren already, and he serves as our academic chair to ensure that our T's are crossed and our I's dotted and so on and so forth in terms of our process. And we'll talk a little bit about our process in a few minutes. Dr. Flores, very instrumental as well, very connected internationally as well, and he provides a great deal of support to our efforts as well. He certainly has a lot of love for the Latin Caribbean. So he does a lot of work down there as well in his business and also other endeavors. And Dr. Kennedy is out of Atlanta Fire Rescue. He's the first deputy chief there. Very connected as well in terms of the National Fire Academy expertise there and also accreditation initiatives as well. So Dr. Bayer is part of our team. As we mentioned, Chief Richards introduced himself. He's been the foundation to not only the vision for this registry process or this advisory council, but importantly also his contribution to CAFC certainly cannot go unnoticed. And Doreen, she's been very well done very well in terms of contributing to the efforts of the Caribbean, not just through CAFC's registry, but certainly through our own consultant practice across the Caribbean. So I want to just acknowledge the individuals here. Jermaine McFarland joined us recently. Someone's added. Get in the room. Joined us recently, certainly a professor as well, a competent individual who brings a lot of competencies and skill sets to the process that we have established. So the goals essentially of the Emergency Registry Council, if you may, focusing on the development of a Caribbean initiative, a strategic plan aimed at not only addressing the scope of practice, but also the standardization of credentialing across the Caribbean so it can be recognized as a basic level of competency. We provide support as an advisory council to CAFC because certainly we're just individuals if we're doing things alone, but under the guidance of the body of CAFC, which have fingers and connections across the entire CARICOM, we're able to hopefully influence change as it relates to not only emergency medical services, but in essence, emergency services as a whole. Certainly looking at how we continue to inquire about different operational practices across the Caribbean and how they're influencing patient outcome, how they're influencing visitors and the experiences that they have with our pre-hospital care in the Caribbean is also one of our goals. The most important goal I think that we have established is establish what we call a registry. A lot of individuals have heard about board registry for nursing and physicians, and also in the United States there's another registry process, but our process focuses on a system that evaluates not only psychomotor competencies, but cognitive competencies across the board so we can establish should I say, a repository of credentialed individuals who can be available for deployment in case of natural disasters and so on and so forth when we're called upon through SEDEMA. So also establishing minimum guidelines where our goal is to work with academic institutions. We've established a great relationship with the University of the West Indies. Ryan Rufus has been very supportive of our efforts. Dr. Das Gupta, who's over the pre-hospital program there, has also been very supportive of our efforts, along with other physicians. And certainly we continue to reach out to different academic institutions so we can establish a framework that recognizes the institutional educational efforts locally and ensure that it's a standardized approach that is recognized across the entire Caribbean so there can be reciprocity as individuals move from from different Caribbean islands across the board. Certainly looking at the firefighting and special operations and dispatching also, those are elements of our initiatives. So registered participants so far, as you can see in green there, those are countries that we've been successful in deploying our model. We piloted it years ago in Jamaica, and we've continued to develop our processes. St. Martin was one of the early adopters of our process and invited us to come and validate what we're doing in their country. So we're very grateful for that, in addition to Jamaica and other countries. So as you can see there, we don't have a lot, we're not there yet. And I think that's why it's important for us to have a discussion today about what we're doing and see how you as stakeholders who are engaged in different elements of pre-hospital care or hospital care or in the legislative areas can certainly contribute to our initiatives as we move forward. But those are the countries that have actually had our processes done within their country and have completed the registry. So as you can see there, the patches we have a number of different patches. Our focus right now is the fundamental pre-hospital care providers, if you may, the first responder level, the EMT basic level. But certainly we have the capacity to advance all the way to the paramedic level or the advanced EMT level for that matter, and also broaden our scope by looking at the firefighter credentialing opportunities and even the chief officer credentialing opportunities. So that's kind of where we're going with this whole model, that we're definitely looking for your support. Some key focus areas I think that we've identified, not only through the agenda for the future that has been recently updated in the United States, EMS 2020 agenda, but the 1996 agenda talked about 14 key elements. And I think as a fundamental thing, there are two elements I think that's missing across the Caribbean, and we all agree within the CAFC registry that medical direction is very important and vital to the success of any endeavor that's being done by non-physicians as we relate to try to deliver pre-hospital care and hopefully impact patient outcome when they arrive to the hospital and ultimately their stay in the hospital. So with that comes legislation and regulation. Only 2 countries have legislation and regulation that are specific to EMS, and that's the Bahamas and Trinidad and Tobago. So I think it's important for us to recognize that there's a gap there, and I think that we think that that gap can be addressed by establishing a framework that will build trust within the pre-hospital arena and ultimately within the formal arenas, if you may, in terms of establishing legislation. Just a couple quick pictures as I wrap up. Some pictures in Barbados, in Antigua and Barbuda. We met with the Ministry of Health, and we're not rogue. And the idea with this is that we actually engage with stakeholders who provide guidance in terms of say, yes, you can do this, no, you can't, because individuals who are trained as pre-hospital care providers, really, we can't function without the direction of medical oversight. So that is an important element that we feel very strongly about in terms of as we move forward and expand in this broad framework of a registry for pre-hospital providers. So that's just some cognitive stuff there. We're going through some written tests and preparing for practical assessments that we do. And with this COVID-19, I think there's going to be an important time for us to really look at how we're actually doing it. And we do have a learning management system that we've established, and we have the opportunity to do distance educational delivery and also assessment remotely as well. So there's opportunities there that I think COVID brings to the table for the CAFC registry as we move forward. Our goal certainly is to have a Caribbean EMS agenda, a Caribbean EMS conference. And I think you would all agree that I think that's probably something that everyone here would probably want to contribute to. So talking about leadership development and so on and so forth will be important as well as we move forward. So we talk about integration of pre-hospital care with other professions, which is very important. And certainly looking at it from a CARICOM perspective is really what our focus is, to not only involve EMS, fire, rescue personnel, but physicians and other persons to increase the political support to standardize pre-hospital care along with establishing legislation that is appropriate across the CARICOM. So moving forward, a Caribbean agenda for the future is needed. I did my doctorate studies in Barbados looking at the attitudes of EMS stakeholders, physicians, nurses, and EMS providers, where examine the affect, beliefs, and behaviors of nurses in an attempt to establish a framework that we can actually model and maybe replicate that study and develop a process that we can actually utilize CAFC's registry process and the advisory council to actually standardize and create a process that will improve the lives of visitors and residents to the Caribbean. So with that said, I'll wrap this up. We're at www.cafcregistry.org. Our goal is to establish a working committee, or should I say multiple working committees. So there's an opportunity there. For those who are online here who want to get engaged, we'll connect afterwards. But certainly I want to say thank you for giving me this opportunity to kind of discuss what the Emergency Services Advisory Council and the registry is about. So thank you. Back to you, Mr. Moderator.
Thank you, Dr. Smith. As you can see, the CAFC Emergency Services Registry is filled with very experienced, highly credentialed members, and we look forward to our journey as we try to develop a Caribbean standard of EMS training and education. With that said, we'd like to move on to Dr. Beyer is up. He's going to talk about the COVID-19 pandemic. Dr. Beyer.
Okay, good night again to everybody. I guess Dr. Smith is going to share the presentation there in a minute. Quite happy to be part of this even though Chief Maynard said it's the first forum. This is the first forum for everybody. The first one was for the chiefs. Okay, so what we're going to do is to talk about COVID-19 and evolving story for pre-hospital care. You know, a lot has changed since this thing first came up late last year. And, you know, even week by week, day by day, you turn the TV on, you look at your medical journals and stuff, and there's something new that's happening, okay? Go to the first slide. Right, so we know basically that the COVID-19 infection is this infectious disease caused by this SARS-CoV-2 virus, yeah? A mouthful, but it's one of these coronaviruses similar to the virus that caused MERS and SARS a few years ago, similar to the virus that sometimes is responsible for the common cold. But it isn't. This one is new, hence is sometimes termed novel, and has really cropped up and caused this major public health challenge worldwide. As it was first identified in December 2019 in a part of China called Wuhan, which is in the Hubei province. But since then, it has really spread globally like wildfire. And to the extent that in March 2020, it was declared by the World Health Organization a pandemic, which means that there's widespread disease in a lot of countries. Next slide. Right, so worldwide, you know, just to have a look in terms of the scheme of things. I mean, I wrote this up earlier today. I'm sure if I turn to CNN or on the computer, things will have changed by the numbers will have gone up. But just to give you in perspective, in terms of worldwide, there roughly been like 4.4 million people infected in the time, with 293,000 deaths or so. Importantly, though, you know, a significant amount of people have recovered, 1.5 million. In the US, which some of our folk here come from, and which we get most of our news from, they have roughly 1.4 million people infected, with up to earlier today, 83,000 deaths, with about 300,000 people recovered. In terms of the Caribbean, so what I've done is excluded Haiti, Cuba, and the Dominican Republic, and the wider Caribbean as we know it, which basically encompasses about 9 million population. We haven't really been too bad. 1,400 people reported infected there, thereabouts, with about 80 deaths and 650 recovered. So that's not too bad in the scheme of things when compared to what's been happening in some places worldwide. Next, right. So this just gives a bit of a picture in terms of by CARICOM country, just to give you an idea in terms of population, how many samples were done, the total cases, the active cases, and the deaths. There's Haiti right in the middle. As I said, I didn't include that in the 9 million population, but this basically looks at most of the countries in CARICOM. This was up to date, up to a few days ago. So it gives a relative picture in terms of what's happening in the Caribbean. Right. So what do we know about it? So we know that this virus is spread by droplets. That's the primary mode of spread. It can also be airborne in particular circumstances, mainly in the medical arena in terms of some of the procedures. They've also found, I've tried to put some of the asterisk star stuff that is not commonly said, that it also is a fecal oral spread, which means that it has, like gastroenteritis to some extent, it can be spread with dirty hands, poor hygiene. Now, the main thing in terms of droplets, either you inhale it or it goes through your mucous membranes in terms of the eyes, or so in terms of direct exposure, if someone is coughing, sneezing, even talking, whereby you produce droplets. But also there's indirect exposure, whereby that it can settle on fomites, inanimate objects, and the data shows it can be there for up to 72 hours, depending on the substance. So you can also then touch these substances, put your hand into your face, nose, etc., and be infected that way. The general incubation period is felt most commonly to be 4 to 5 days, but the range usually between 2 to 14 days. There are other reports that suggest it may even be longer than that, but that's the usual average of what is happening in terms of incubation period, from time of exposure to time of any discernible symptoms. Right, so when we first heard about this thing, and even in terms of our dispatch information and what we're looking for people with fever, cough, respiratory tract symptoms, who may go on to get worse in terms of difficulty breathing. And we married that initially in terms of testing, in terms of suspicion, with whether at first, whether you travel from Wuhan, then to whether you travel from China, then basically to whether you travel from the United States or the UK. Now, I think pretty much everybody accepts that, you may, in some places, you probably may not even have to travel now. So that pretty much is being kicked out of the whole specter. There are people around who basically may get it from people who have traveled, what they call local spread. The other thing is in terms of change in symptomatology. So it is, yes, people are still getting fever, cough, and respiratory tract symptoms, but some of the noteworthy ones, loss of taste and loss of smell, is something that is pretty much new over the last month that they've asked to be added in terms of things to recognize. Gastrointestinal symptoms aren't much talked about, but these viruses, as well as going through into the respiratory system, they also go into the GI tract and notorious for causing diarrhea. So diarrhea is seen as one of the noteworthy symptoms of possible COVID infection. And in fact, it is said that if you have diarrhea, that you probably may have a worse outcome than if you actually have the respiratory tract symptoms. Within the last couple of weeks, they've found some skin symptoms, some inflammatory vascular changes in the toes and stuff. So it is an evolving specter. Right, so how's the diagnosis made? For most folk, you see on television, they stick a little bit of a longish type Q-tip into your nose to get what they call a nasopharyngeal swab. Whether they do it by drive-by or in an actual place or whatever. Some people couple that with the oropharyngeal swab, where they're swabbing the back of your throat. It goes into the media and it goes to the lab, whereby they use this thing called reverse transcriptase, PCR, which basically is molecular biology. They're looking for the RNA, it's an RNA virus, to see whether they can detect it. There are newer tests coming out whereby you can use sputum and saliva. May not be as accurate as the nasopharyngeal swab, which is still the gold standard, but those are being evolved. The other thing that's happening is that people are now starting to look at antigen tests in terms of actual evidence of the virus in the blood, as well as antibody tests. But these are still works in progress. In fact, the ones that they have now haven't been found to be significantly reliable in terms of their number of false positives, false negatives, etc. So they're still, it's not readily accepted in the medical community. Right, so for most people, and I guess, this is a take home, most people get mild disease if they get symptoms at all. I'll come to that in a minute. And most people recover, as you see from the numbers, how the numbers go. But the other thing is that there are some people who get serious complications and obviously may die. And this is not only happening in adults, as we once thought, but now children are being seen to be infected in a pretty bad way. and there'll be some cases in Europe and some cases in North America which point to this. The bottom line is, though, that in terms of what the virus is causing is a significant inflammatory response, what they call a cytokine storm, which is massive inflammation throughout the body. And with that, you get a hypercoagulable state, meaning that the blood tends to clot easier. And this has been shown in some young people with strokes and heart attacks and stuff as possible in terms of how it got there. But in terms of the major complications, people go on to get acute respiratory distress syndrome, multi-organ failure, shock, and ultimately they may die. Right, so we know now that it affects all age groups, but what studies have shown that you get worse outcomes in the elderly and those with comorbid conditions. If you have hypertension, diabetes, COPD, asthma, isn't that you're more prone to get it, but if you do get it, you probably are prone to have a worse outcome, all right? There's no vaccine at present, but everybody's scrambling to be the lotto type winner to be able to, you know, retire with getting the vaccine. So there are lots of them under development. There's also no specific treatment. There are lots of them under development. There's a drug that you'll hear about called remdesivir, which basically have proven to be of some benefit in severe cases, decreasing the amount of time that you'll be ill. It's an intravenous parenteral drug, so it wouldn't be relevant for people who are mild in terms of taking it orally. It's very, 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 very expensive. And, you know, even the studies that support it aren't that strong. The major thing in terms of care is supportive care. Some of these folks require some level of ventilation, whether it be non-invasive or invasive ventilation. And of course, the patients need to be isolated in a particular medical unit. Right. So the other things that have come up that we need to pay close attention to, I know we're always scared of that person who's coughing, who's sneezing, who's barfing, etc. However, significant disease spread is being found in people who have no symptoms. In fact, there's some studies that are saying that they may be responsible for maybe 30 to 40% of the spread, which means that there are people who are infected who are not ill at all, or there may be people who are infected and they have not had symptoms yet. So hence the move towards wearing cloth masks and stuff like that, because these are a significant denominator in the whole process. We do know that healthcare workers, by the nature of their jobs, are at significant risk from the condition during their close contact with patients. We also know, and now that they're going back, we think that perhaps that this virus may have been around probably a lot earlier in December 2019, that it was basically discovered in Wuhan. And in fact, there's some people who are looking back to say that mid last year, there may have been some cases in Europe and some cases in North America. So because we are big tourism states, there is the possibility that last year, that folk with COVID infection could have visited the islands. There is a possibility then that we may have had some cases before, and there is a possibility that we already have people with antibodies and exposures, and that may contribute somewhat, maybe the jury's out on that, somewhat to our low cases. But in addition, there's no clear data though on the antibodies leading to immunity, meaning that if you have it, there's nothing to say that later in life that you wouldn't get it again. Right, this is the last slide. Now, the other thing that we also need to consider, we are the providers not only for COVID, but we're the providers for healthcare. Now, there are a lot of people, unfortunately, who are falling below the line because of COVID, because most of the efforts basically are geared towards COVID. So we know basically that there's mortality and morbidity associated with COVID, but the second wave, basically what we need to look at is that the resource restriction on the urgent non-COVID conditions. There are a lot of people out there with diabetes, hypertension, who have not gone to their doctor because of COVID. They may not have medication, and that basically may contribute to another wave of actual patient load within the next coming months. In addition, as you see with the fourth wave, It also is contributing to mental illness, to burnout, problems with the economy, and general mental trauma. So that's it in terms of an overview. I guess we can have questions as we go along.
Yeah, Dr.
Over to you.
Dr. Byard, thank you for a great presentation. Quick question, in terms of the Caribbean and kids having exposed to the Kawasaki type syndrome where the febrile and they get acutely sick. Are you experiencing that in Barbados, or are you able to speak to that, sir?
So I don't think we've had a case of that there just yet. I don't think we have been exposed to that. And I don't see it in the ER chat in terms of the Caribbean, but that's open to comment, I suppose, when we get to the question and answer.
Absolutely, absolutely. Thank you very much. Back to the moderator.
Thank you, Dr. Byard, for a most informative and enlightening presentation. Certainly, I learned a lot. So thank you, sir, for doing that. We're going to move on to what we call some hot topics. And as we decided what we wanted to present, some of the hot topics are going to be based around preparedness, response, and decontamination. And to lead us off will be, once again, Dr. Byard, who will talk about COVID-19, the COVID-19 perspective. He being the medical director for Barbados Ambulance Service, he will give us his perspective on COVID-19. Dr. Byard, sir.
Right. So it wouldn't be right if I don't pay homage to the brave men and women who I get the pleasure of working with on a daily basis in terms of the ambulance service, as well as our colleagues who basically work in the emergency room or so. So my hat goes out to all of you in this Caribbean forum. Now, in terms of what we have done and what we've seen, let's just go to the first slide. So this is the picture as of today. So for Barbados, we've seen 85 cases. There are 21 isolated at present in one of our institutions for isolation. We've had 7 deaths, unfortunately, and 57 people have recovered. And the criteria for being deemed recovered is that you have 2 negative swabs on consecutive days when all the symptoms and stuff have gone. And they would have satisfied that, and they now are basically back into the community. Right. In terms of what has been done around here, so we have 4 active isolation facilities or so. I mean, things had to be, credit to the governance of the land and all the health administrators. They had a quick plan in terms of having some standard facilities, which included field medical facility. And now that was, whilst those were up and running, they were with the master plan of a place in northern Barbados, what we call Harrison's Point, the old naval base, where they found some buildings and they actually restored it to now a large isolation facility. So we have 4 active isolation facilities, one just inside the hospital, one close to the airport. There's a school which they had commandeered for patients, and now that old naval base as we spoke. The capacity for critical care patients is roughly about 60. We're talking about 60 spots for which you can ventilate, which is good, and they have the ventilators which can actually service those patients. There's another capacity for over 100 less severe cases in terms of moderately or mildly ill, but certainly moderately ill that can have access to medical gases, oxygen. So, but there's also the capacity to ramp up where they have field medical hospital and other identified centers where if the numbers get large, the proposed surge that you can have basically added patient care facilities. All of this is with the whole thing. You want to the next slide. All of this is with the thought process is that we have one single main tertiary hospital, 600 plus beds, and the powers that be are committed as best they can to keep COVID infections outside the main hospital where there are a lot of vulnerable people, the elderly, the sick, etc. So these measures have been put in place to try to protect the single main tertiary hospital. The A&E department basically has been divided into 2. There's an external triage out close to the ambulance bay, and then patients are shunted to particular areas based on their triage and their risks. We've also added a clinical decision unit. Now, from actual getting a test to a result, that can be anywhere from 6 hours up to 24 hours. What was happening initially was that these patients were just staying in the A&E beds and not a whole lot of flow could happen before these tests came back. Someone came up with the idea that we can stand up a facility where we can transfer the stable patients out while they await their test results. And this has allowed for better flow within the accident and emergency department. Next slide. Right. So in terms of what we've done, back by one, in terms of what we've done in terms of the pre-hospital arena, we've transported on a daily basis multiple suspected cases, which are referred from the COVID hotline. So this is a hotline which is set up whereby if you think you have symptoms, you think you're ill or whatever, you call this line and they coordinate care for you. We've also gotten referrals from various medical facilities and of course, community referrals, people calling the emergency number to ask for help. Our dispatch process has evolved, as I said a few minutes ago. So now, before it was whether you had travel history, whether you were, fever and cough and stuff. Now we recognize that with the whole vast array of symptoms, some of that there has been modified. So we basically, in our minds, you're COVID positive until proven otherwise for most things. We have a low threshold for PPE use in terms of, as a minimum, surgical masks and gloves, and we ramp that up depending on risk. And we try to have protective measures for all the patients in terms of how we view them, and that's basically a staff safety perspective. Right, so what we've also tried to do from the time that we recognized that this year was eventually coming, we had enhanced training in terms of PPE. We've actually started to do lots of simulations. So we've basically different transfers of COVID positive patients, transfers of pregnant patients, transfers of pediatric patients, ventilated and not ventilated, so that we could get a feel for what needs to be done when the time comes, and that has served us well because we've had some real activity after these simulations. So I think it was really good that this idea had come up from the team. So our main thing is to try for preparedness. We are not only concerned with ourselves, we've reached out to our fellow first responders, and we've done some training with the police, the fire service, the prison service, the private ambulance services here, and we've reached out to the home health and elder affairs. These are the folk who go to the elderly's homes and feed, bathe, etc., because we recognize that they needed to know how to recognize and how to manage themselves. So we've done outreach programs with these groups. Right, so we've actually been involved in inter-facility transport of COVID-19 patients, both ventilated and non-ventilated, and it's been a cooperative effort with the critical care specialists, the anesthetists, the infection control specialists, and the emergency department team. As we all know, transport medicine is different to doing it in a building, so it's been good that we've been simulated it, and it's good that we've worked together in a cohesive fashion to execute it. Right, this is just some pictures. This is basically our prep for one of those inter-facility transfers. I have the initials there to remind me who they are. But so this is the TVET suits and stuff like that there in terms of what we do those high-risk transfers in. You see the guys in the N95, the face shields, etc. We try to give them as maximum protection as possible. Right, another picture on the left is in the TVET suit. On the right is basically, because sometimes we don't use a TVET suit, sometimes we use a gown, the N95, and booties and stuff, depending on the risk and depending on terms of what's available. You must remember that this is a highly tropical climate, most days 30, 31, 32. You don't last long with the TVET suits, you don't even last long with the gowns, and it's something basically for us to consider.
Awesome.
Right, so again, this is the ambulances we use. We've had to do some stuff with the ambulances in terms of separating the patient compartments from the driver compartment. We'll talk about that a little bit later. Right, so what are our critical learning points? So we know that everybody must go home safe. So all our movements need to be deliberate, planned, and unrushed. The other thing is that we've been bitten by not getting the correct information from patients or caregivers, including some of our medical colleagues. So we are basically trying to keep our head on at all times, maximizing safety, keep your head on a swivel. I think that's the term that they use. And we've had to modify procedures to ensure staff and patient safety with respect to resuscitation now being chest compressions only, the asthma care moving from nebulization to spacer and mask, and even in terms of PPE care and ambulance cleaning. Right, so just in terms of some donations and innovations, I must say the general community has been quite good, and even some of the guys have been quite innovative in terms of making their own masks or having their significant others make masks for them. Just give some ideas in terms of what they look like and what they wear in terms of, these aren't the medical masks, these basically what they wear in terms of for their regular interactions in terms of the service. Thanks.
Thank you, Dr. Barrett. What's your protocol for if any of your pre-hospital care providers, any of your EMTs or paramedics have been exposed?
Right. So if they're exposed and stuff, we basically do, well, the testing is normally done in terms of the patient, but we are moving to a position where we consult with public health and be guided by them depending on the level of exposure. If it's a high risk, they may be quarantined from work for 14 days with the adjunct in terms of testing, and that has happened to us as well.
Excellent. Thank you. Thank you for another excellent presentation. You're becoming the star. So we're going to move on to Dominica Fire Services. Dr. Chief Dupuy is going to talk about preparedness, response, and decontamination. Chief? Chief Dupuy?
Hi, Dr. Warren. I may be having some difficulties with my signal now. I actually just got home and I'm settled. Seems like my signal was much better while I was driving. To do with the decontamination and sanitization. Basically, what we did when we have in our first registered case in Dominica, we had some training conducted by PAHO and our Ministry of Health. And we first, well, they identified 6 fire officers. Well, they gave us 6 spots, so we had 6 fire officers attend this training. The training was specifically to deal with wearing of PPEs, how to don and doffing of PPEs and disposal of PPEs, and also to do with sanitization and decontamination of our ambulances. These are not areas that are necessarily foreign to us in the fire and rescue business, but it was still very good that it was a good opportunity for us to receive training specific to a virus like the coronavirus. And so once we received that training, what we did is we did some internal training, enrich. So we basically had the entire staff of our organization receive the training that the 6 fire officers got. And shortly thereafter, I met with my senior managers and we developed some protocols specific to our response to, what would eventually be our response to our the COVID-19. And so the response really spoke to areas such as how do we treat with calls that we suspect or we are told are related to the coronavirus. How do we manage these calls in terms of the assets that we deploy? So one of the things we did was very initially, we identified 6 ambulances that we strategically deployed in areas, and we said that those ambulances would, for the most part, be exclusively utilized for COVID, the COVID cases or suspected COVID cases. And that has worked very well. What we went on to do further was to organize or basically build an area for doing the decontamination and sanitization. Of matter of fact, it's a bit of a joke at the fire station, because we thought that the orderlies at the ambulance at the hospitals were going to do the decon of our ambulances. And by the time we had done our first run, we were told, no, it's for us to do. So very quickly, we went on and built this bay. And in every station where we have such a vehicle, we have areas identified for us to basically do our decon and sanitization of the ambulance. Subsequent to actually putting in, well, let me just give you a few more elements of our protocols that we developed. At the stations itself, we organize a few more sanitization areas where we got running water into into basins where you have that, obviously. We have this coming station. I must say too, as it relates to our protocols, we actually made 3 adjustments determined in ensuring that we have a protocol that would meet the needs. And so we didn't on day one have that. So we had actually 3 adjustments.
All right, Chief Dupe, you're going in and out. Your connection is kind of wavering. Chief Dupe. So I think he's communicated most of his key points that he indicated that he wanted to share with us, and I'm hopeful that he will reconnect and wrap up if need be. Back to the moderator.
Thank you, sir. With that said, let's move on to Jamaica Fire Brigade, and Deputy Chief Kevin Houghton will discuss preparedness, response, and also decontamination.
Thank you, Dr. Warren. Good evening again, everyone. As it relates to the Jamaica Fire Brigade response, firstly, we have 34 fire stations across the island of Jamaica, and we have 7 EMS sites operating out of those 34 fire stations. Before our first confirmed case, we as a management would have been monitoring what was happening overseas. We would have conducted sensitization sessions and training, read the use of PPE. We would have checked our inventory, and we would have done some forecasting as it relates to our call runs. One of the things from early, we had planned that once we had our first confirmed case, what we will do is to treat our regular runs, both medical, OBGYN, trauma, calls as possible suspect cases. So this means therefore that we had to ramp up our procurement in terms of PPE, and the reorientation was critical. We take our medical directorship from the Ministry of Health and Wellness, and we would have conducted joint training in terms of preparedness and response. We would have, in all our 34 fire stations, installed hand washing facilities. once you enter these premises, we would have implemented temperature screening procedures and policies. We would equip each ambulance with dispensers for sanitizers as well as temperature guns, so that there is not a need to, from a distance, you could check the temperature of a patient without getting close to the patient. We would have screened all our calls that we respond to. We would have a high index of suspicion once we realize that we get calls from those areas with the highest confirmed cases. We would have provided the necessary PPE, such as goggles, gowns, N95 masks, surgical masks, ensure that we have bag valve masks on all our ambulance. We would try not to commit our crew that respond in our ambulance is 3 persons. We try our best as a last resort to have the driver being a part of the patient management and care. So before we commit anybody, we always ensure that even responding to our regular call runs, if we meet on a situation where there's a crowd, we always encourage that the crowd disperse so that we don't interact with the crowd. And we ensure that the necessary protocols are observed. One thing with this COVID-19 virus, we learn every day something new, every week, like a moving target. So we constantly have to monitor what is happening both locally and internationally and make adjustments where necessary. Our decon procedures, initially we were told that when we go on suspected cases call runs, we would be able to decon at the hospitals, but not all the hospitals, the receiving hospitals had that facility. So primarily when we respond to suspected cases, we have to do decon back at the state. We have a robust decon procedure and practice. So we ensure that because of EMS, emergency medical service, and the firefighters share basically the similar accommodation. So therefore, we have to put in a robust decon practice so that there is not contamination of our regular firefighting, because we don't have separate living accommodations. They share the same common areas and dormitory space. So we had to put in a more rigorous for our EMTs. So basically, that's what we do as a country in response to COVID-19. And from here, I'll take any questions.
Moving on to Captain Will Hall. As we know here in the United States, especially in Florida, the Miami-Dade area has been the epicenter in Florida for the most number of infections. And we're most fortunate to have Captain Will Hall from Miami-Dade Fire Rescue. He's also an RN, he's a paramedic firefighter. So he's bringing to us a very unique perspective. And I'm certainly looking forward to hearing what he has to tell us and educate us and inform us. So, Captain Hall.
Good night again. Thanks for having me. You know, a lot of times when we think of preparedness, we think of what we are going to do as first responders. But a lot of times we don't think about educating our guys so they could feel comfortable doing their job. Here at Miami-Dade, we're fortunate where we have an infection control group that consists of over 30 nurses that are certified with ICN that could help us with research to be able to get information out to our guys so they could know what they should wear, what the disease or the virus is doing. And that's where we started. We started educating our guys to let them feel comfortable. This is what you need to wear. This is what you don't need to wear. This can't happen during this virus, that type of thing. And we're fortunate that our medical director, Dr. Gerald Job, was very proactive. We started using N95 masks very early in this pandemic. So every call that we responded to, our guys were wearing N95 masks. We had a CAD system would be able to identify what the signs and symptoms are of the patient. If we had any flu-like symptoms, and as this virus evolved, our dispatchers and our CAD system evolved with it. We heard a doctor talk about symptoms as far as loss of taste, diarrhea. We included all of that. And for our EMS, I mean, it became a lot of work, but we know we wanted to do what we could to protect our guys. So once anything got coded with COVID-like symptoms, our guys knew that, hey, we got to ramp up what we're going to do. Every call from this pandemic started, we started wearing N95 masks. If the call required or got coded with COVID, we had our gowns were worn. We took care of our guys as far as if the patient came back positive or just suspected, we were excluding our guys early in the process. We weren't waiting for results to be positive. And you know, this is not a knock on the CDC, but what we found was the information we were getting from the CDC wasn't being updated as this pandemic was evolving. So because of that, we had to do our own research. And with the help of Dr. Job and his guidance and our nurses, we were able to, I won't say do more than, but we were proactive in making sure we taking care of our guys. So again, like I said, N95 masks worn on every call, PPE upgraded as needed. And we even went as far as our employees that are immunocompromised, right? We had systems set up where they weren't out in the field during the time when this COVID was ramping up. So those are things that we did on the preparedness side to take care of our guys. There are also some, as far as responses in taking, as far as the truck and the decon, we are fortunate here in Miami where we have a robust hazmat team that would actually follow all our rescues on all our codes. So we coded certain calls, certain activity, if they were doing any aerosolized treatment, if we had a code, if CPR was produced, if CPR was done, those calls would be, a hazmat unit would follow that rescue to the hospital. They would decon the rescue at the hospital so we wouldn't be taking back that situation back to the fire station. So, you know, we understand that here we were fortunate to have, access to more equipment than we typically would have in some of the third world countries, and we're able to use them. And again, because of that, our numbers are down, and that's pretty much our preparation and our response and our decon. Any patient that was coded as COVID or anybody who presented with flu-like symptoms, within that response, we would have our guys in full PPE. Within that process, we would have our hazmat unit and an EMS captain, which would oversight and help give our guys guidance, because a lot of times, because of the fear of what's going on, we'd make sure that patient care was still being administered to the best of our ability, but we wanted to take care of our guys. Take care of our guys is always the number one thing. And then with that response, our hospitals, most of our hospitals are set up with a receiving site where our guys are not going into the hospital. They have a receiving tent outside where they'll collect those patients. So we're not exposing our guys. We're not exposing the nurses and the physician within the hospital. So that exchange is taking place with what they would consider the COVID team. They'd accept that team, that patient, take that patient inside the hospital. We do our decon process, and that's what our process was like. Any questions for me?
So that's great. Now, are any of your colleagues, your neighboring fire departments, are they following the things you're doing?
Well, we have, you guys mentioned Jermaine McFarland, which is a good friend of mine. We actually teach together at Miami-Dade. We bounce information off each other. To be honest with you, Miramar was ahead of us with having the HEPA filters on the BVM. I actually reached out to him. He gave us the information, and us being a bigger department, we were able to get those HEPA filters when they stopped using them and they had a hard time getting them back. So, I'm fortunate that there is probably not a fire department where I haven't had somebody that I taught, because I've been teaching on the EMS side for 13 years. So I know somebody in every department where we're able to bounce information off. I think the difference is with Miami-Dade, we're utilizing our nurses as part of our infection control team. We don't have a lot of fire departments that are doing that. So you have nurses just like a Jermaine and many other departments, but they're not being used in that capacity. Our medical director has allowed us to formulate this team where we're used in this area, and I'm telling you, it's showing in the number. We're a fire department over 2,700 firefighters, and to can't give you the numbers, but I'll tell you less than 1%. It's phenomenal. And we're given the green light to be able to, if we think it may be, it is. So I give you a quick scenario. We respond to the borders of the airport and the port. So we have units that's specifically for the airport. We had a patient that came, 42 years old. He had flu-like symptoms, but the guy was 42 years old. He ended up being a cold, right? And typically, as per CDC and most guidelines out there, you would wait for that guy's results to come back before you would exclude your firefighters from work. So we were allowed to, while waiting on that result, exclude those firefighters from work, right? We have a limited amount of crew that are airport certified, right? So our thought process was, if we were to have those firefighters go back, that guy is positive, they were exposed to him, we could take out all our airport guys. So those guys were excluded until we got the results back. And the results, to be honest with you, 3 to 5 days is what we're getting, because we're at the liberty of the hospital, right, or the ME's office if the patient's deceased. We have laboratories where we can't share the name of the laboratories because we're getting results within 24 hours. And if we share the names, which we did once before, that 24 hours became 3 days, then 5 days. So in taking care of our guys, we got to take care of our guys, and it's a robust team. I'm proud to be a part of it. We're now taking care of corrections. We're going to be doing all of Miami-Dade employees, including the PD department. So that's pretty much our preparedness, response, and our decon.
Excellent. Nothing like collaborating and networking.
Absolutely.
And it's only befitting that, along that vein, I know that you and Dr. Smith have had some conversations about COVID approach and what OFD is doing versus Miami-Dade is doing. So it's only befitting that he follows you to talk about what he is doing at Orlando Fire Department. So, Dr. Smith.
Yeah, so I thank all the speakers ahead of me, but certainly very appreciative of Captain Hall for his information that he shared, and connecting with him was one of the most significant things that occurred over this COVID period. And the Orlando Fire Department is very small compared to Miami-Dade. We're about 110 square miles, about 500 personnel, 17 stations, and we're a fire-based EMS response agency. Basically, we're the primary response agency. We actually take patients to the hospital. We are supported by civilian paramedic units as well, about 6 paramedic units and 11 transport ambulances that have firefighters on it. And we work alongside a public, a private agency as well that they get a small number of our calls. So late January, early February, I should say, the leadership of our department, under the new direction of the new fire chief, determined that it was important for us to establish an operational framework that would support the potential, the pandemic as it started to across the country borders and state borders and so on and so forth. And it was important to adjust and ensure we had a continuity of service and ensure that we prepare our responders to continue to provide the utmost level of service to our citizens, but while doing it in a safe and efficient manner, and ensuring that the department continuity in terms of operations would not be inhibited by individuals becoming exposed and so on and so forth. So we established, the senior staff, we established what we call an incident management team, which is an element of the NIM system in terms of the incident management structure. And basically that incident management team comprises of what we call a department operations center. And essentially they're elements of a ICS structure that was established within the organization on a small scale. While we did activate our EOC virtually, if you may, but we established a planning section, an operations section, a command section, health and safety. We had some additional emphasis on health and safety, logistics, and also intelligence. My role within the doc, as we call it, was the academic intelligence officer. And my goal with that, having connections with IT, the CAD system, and so on and so forth, some of those things that Captain Hall referenced, we actually implemented them. We activated what they call the pandemic EMD code or EMD card, so we can do the proper screening. And it evolved, as he indicated. But one of the most important things I would say regarding my role as an epidemic intelligence officer is actually to engage stakeholders from various areas in terms of not only the hospital providers, the various receiving facilities, but engage with state and local EMS and medical professions to gather information, intelligent information that can be shared and to address our operational needs as it relates to whether we're responding to the calls, how many people, how many providers are making contact with the patient, and so on and so forth. GIS also played a significant role in that because we wanted to identify where these cases are occurring, and we wanted to be able to notify our providers ahead of time. So I actually learned our GIS pretty quickly in terms of trying to determine, okay, how do we plot this thing? You know, how do we engage IT to actually do it in a more efficient manner, whereas providing senior staff and city government officials with information that's coming in from the Department of Health, the state, and also coming in from our local hospitals. So that was an important thing in terms of trying to have information readily available to influence our operational framework. And getting information back, you talk about 2 days, you talk about 24 hours and so on and so forth. We were getting information back from the hospital as soon as they found out. We didn't wait for our health data exchange process, which is a component of our electronic patient care reporting software application, where we have a connection with the local hospitals. So when the diagnosis is entered into the patient's record, it actually transfers over to the EPCR side or the health data side for our providers to actually see the outcome of those patients. So we were able to adapt our responses in terms of getting an idea who potentially is a positive case or who is not tested. And I felt it was also important to identify calls that the patient tested negative, because we talk about the psychological impact of our responders, not knowing that the patient they just transported or the 10 patients they transported last night when they got off in the morning, did they test positive or did they test negative, so they can have some sense of relief or some closure. So that was a very important role in terms of getting that information. So when we talk about PPE, we talk about the strategies, the typical strategies, your N95, your mask, and so on and so forth, in terms of your eye protection and all that. Minimizing your advanced airway procedures in terms of utilizing supraglottic airways versus actually intubating the patient. We actually adjusted our protocols in alignment with our guidance from our medical director. So those things were important in terms of keeping our personnel safe and ensuring operational readiness. Dr. Beyer, I think Dr. Chief Dupuy actually talked about separating the ambulance compartment areas, the patient compartment versus the driver compartment, things of that. So those things were actually done. And then we actually implemented strategies that would actually ask the patient to come outside to meet us and limit the amount of people that actually engage with those individuals, those patients, those customers, as we call them. So those things were very important. And as I transitioned to the decontamination, something we did early in our years of establishing relationships with hospitals, the hospitals actually purchased decontamination equipment. to assist us and provide it to us to utilize. We utilize a product that's a local company, actually, I'll call the name, Aeroclave. Very effective at decontaminating our units, but also our stationary living areas, because as firefighters who work 24 hours on, 48 hours off, it's our home. So we have to not only decontaminate the sleeping areas, the common areas, the gyms, and so on and so forth. Those are some things that we wanted to make sure that we accounted for. So with that said, I think the decontamination process has worked very well. And in terms of outcomes from our patient, less than 1% of the patient that we've transported, because most people, I think most agencies, probably even in the Caribbean, can say that, you know, there's a decrease in call volume. And subsequent to that decrease in call for service volume, we were also experiencing a decrease in transports to hospital, hence an increase in refusals. But in spite of that, we wanted to make sure that we had the operational intelligence to adjust as we needed to ensure that we can continue into this new phase, as we say in phase 2, if you may, in terms of not demobilization, but actually making that transition, not back to normal operations, but to a scale down operational framework while maintaining our intelligence related to COVID-19 and minimizing any potential exposure. So with that, I'll yield to the moderator, who is not at his camera. No, I'm just joking.
Thank you, Chief Smith. Excellent. How often are you deconning your sleeping quarters? Like once a day, or?
So interestingly, I'm not muted, right? Interestingly, we actually have a decon team, not as robust as Captain Hall there, but we have members who are on light duty and some other members that we were able to actually, once we got an additional Aeroclave machine, we said, okay, your task will be to support the decontamination needs of the stations, the gyms, and also hazmat plays a role with that in terms of if they need to respond to the hospital, if the hospital doesn't have, if their equipment is out of service or they're low on fluids and so on and so forth, we're able to share those resources. So actually we do it quite frequently.
Excellent, excellent. Thank you. Thank you, Chief Smith. So far, we've talked about preparedness, response, decontamination, and Dr. Smith just talked about department operations. And now it's a good time to have Dr. Beyer talk about infection control guidance.
Okay, so I guess we'll just put the presentation up. Another few slides. My memory is going, so I need the slides. Right, so in terms of infection control guidance, so there are some things that basically the countries in the Caribbean have done in various ways in terms of limiting infection in terms of the islands. So, I mean, right now, we here on the curfew, we're between 8 p.m. and 5 a.m. in the morning, roughly. There's nothing that moves up there except the essential services, essential workers or so. So they've made some changes in most of the islands to try to limit the actual viral spread. One of the first things they did was travel restrictions. Well, I mean, the airports in some places were closed, but that was accentuated by the fact that some airlines, the American Airlines, the JetBlue, British Airways, Virgin, the major ones, they stopped international travel. So there's not a lot happening with respect to air travel within most of the islands. And that also goes in terms of cruise ship travel. There are lots of cruise ships parked outside our harbors now in most of the islands. We've tried to limit population movement. So there are no parties, there's no church, there's a lot of stuff is done online. In fact, for us, there's no crop over. And for most of you who don't know, this is our carnival, which usually takes place from July to August. So that's been canceled. So that's just the extent for which they have gone in terms of to limit the population movement. To go to the supermarket, you go by your surname. So I'm B, so I have 2 half days a week or so to go to the supermarket or the store. The only exception to that is if you're going to the medical facility or the pharmacy. So they've tried to limit movement, tried to limit in terms of people's contact with each other. We've tried to encourage public cloth mask use. So a few weeks ago, it was determined that even within your normal speech, that we call down here golf balls, but anyway, the secretions from your mouth and stuff like that there when you speak can actually transfer droplets. So now everybody is encouraged to wear cloth masks. So you find people all around the place in cloth masks. And again, social distancing is also being encouraged. So when you see the lines to the bank, you see the lines to the supermarket, everybody's roughly 3 to 6 feet apart, all right? Right, they've really ramped up in terms of hand hygiene. This whole thing with washing their hands for 20 seconds with soap has really taken off. So people who never used to wash their hands before in such great frequency are now washing their hands. If they don't have the water and stuff, and again, in a lot of the countries now, there's drought. So that's something to contend with, in that there's some countries and in some areas, even in Barbados, where the water may be off for a portion of the day. So in lieu of having water and stuff, hand sanitizers with the appropriate amount of alcohol, greater than 60, 70% alcohol is usually recommended. And you find that basically most institutions have hand sanitizers all around now with easy access, and people carry their own home sanitizer. We try and encourage people to limit facial touching in terms of having their dirty hands to their face where they can actually expose themselves to virus. Remember that the virus basically may live on fomites in terms of inanimate objects. So a lot of places now are having enhanced cleaning of the surfaces, perhaps with a bleach 1 to 9 solution. People are using bleach and other surfaces to do ramped up cleaning. And of course, we're trying to encourage everyone in terms of cough etiquette, not to cough in the open, but basically either to cough in a tissue or into your elbow or so, to limit the spread in terms of droplets. As far as specifically for pre-hospital care, there are a couple of things we got to bring on stream. So in terms of the transports, so we basically, for all the transports which we think may be COVID, there's no AC running in the patient compartment. So we turn it off and we open the 1 or 2 windows in the back. So depending on where you're coming from, it could be a fairly hot ride depending on the time of the day, especially in the PPE. And I mean, this is something that, you know, that we face in tropical countries, which you guys may not face yet in North America, but certainly in the summer, I'm sure that, you know, that it'll be something to consider. But that's what we do a lot in the Caribbean. If we have an extractor fan in the back, basically we turn that on to take the air out to create almost like a little bit of a negative pressure environment. We have done, try to segregate the driver's compartment from the patient compartment. They have come up with a really ingenious, the construction plastic, the one that you put down just when you're laying a foundation, the clear one. So we have that there taped up to basically distinguish between the patient compartment as well as to the driver compartment, whether there's a little porthole or so. So we have basically duct tape on that, and we change it ever so much. So that has proven good in terms of segregation. And as we said earlier, we have enhanced cleaning protocols for the ambulances in terms of bleach solutions, as well as for the equipment in terms of alcohol or other cleaning solution. The thing with PPE, we spoke about a little bit about it and stuff. Again, and I hope somebody mentions it, in terms of wearing PPE, we know that there's a shortage, but again, in our neck of the woods, we know that it's quite humid, it's quite hot. If you wear the mask for maybe close to an hour, it'll get wet and then it becomes ineffective. So, you know, that's not an option for us. We have to change them quite frequently, much sometimes to the chagrin of our procurement personnel who's wondering why we're using so much PPE. But that's the nature of the beast and stuff in terms of working in a hot environment. We also encourage in terms of careful doffing of the PPE, because when you're taking it off is when there's the greater infective risk. And that's something that we pay a lot of emphasis on in terms of making sure you take it off slowly, you take it off carefully. Even sometimes, you know, it may cause a little bit of a call delay in terms of transition, but the important thing is to do the thing carefully and safely. Right, in terms of our dispatch and communications, as I said before in the previous slide, we might had to modify that in terms of basically the dispatch, try to get as much information as we can. But again, we have a low threshold for calling a case a COVID case. Our communications in terms of pre-alert and notification of the receiving facility, which is the main hospital, we try to enhance that. we have to be acutely aware in terms of the country procedures for quarantine and isolation. Unfortunately here, if you have a case, you're automatically institutionalized in terms of isolation. So we don't have home isolation just yet. I think that happened because they got bit a little bit in terms of the first few cases where people who were isolated didn't actually pay as much attention to what they should be doing and found their way into the community. So they've taken a stance here that basically that to keep a really good eye on you, for the most part, if you have it asymptomatic or not, they basically isolate you in terms of one of the centers for the prescribed time. In terms of, as I said, in terms of the specialized medical units of patient care, pre-alerts, and then the organized transports are key because we want to make sure that we do everything correctly each and every time. Right, education we spoke about. Education is a continual thing. It's not just a one-off, and it's both internal, but also external. As I mentioned, we've tried to help our fellow first responders, as well as susceptible agencies that spoke about the home health, elderly caregivers before, and we are trying to use simulation as best we can to practice things that basically we may encounter. Right. As far as the departmental procedures go, I mean, again, we don't have a big stick in terms of from our HR, but we encourage social distancing. You know, we live in an environment where the girls like to talk to the boys and boys like to talk to the girls and stuff. You know, that's our nature. Everybody jokes around, everybody hangs around and stuff like that. But we're trying to enforce in terms of social distancing, and to also, we've tried to move some of the beds out of the main dorm to create a distance, some relevant distance between the actual beds and the dorm. The cloth masks, we're trying to encourage folk to wear them on the compound. Obviously, when they're dealing with patients, they move to medical masks. Temperature screening is something that's new and has just started, and we haven't got it right just yet, but it's something basically that's done in the hospital where if you enter, that usually your temperature is screened. And we're trying to basically put things in place for what happens to the exposed worker, as you asked, what happens to the ill worker? If someone thinks that they're ill, what do they do? And also, importantly, mental health, both acutely after a call and also chronically, because this thing takes a toll on you. And not only just the work, but certainly the actual curfew. There's no chauffeur. I know that you guys smile at that. That's one of our major fast food places here. There's no oysters. There's no the things that you normally do to sort of get yourself back mentally. There's not a whole lot of that there happening. It's work, and then you go home, and at home maybe it's worse as work. So you know it is really a struggle mentally. So we're trying our best to see what we can do in terms of our folk. Thank you.
Thank you, Dr. Barr. I am most disappointed to hear there's no oysters. so moving on, we're going to talk about now health and safety monitoring of fire EMS personnel, and that will be presented by none other than Captain Hall.
Thank you. Health and safety monitoring. We, I'll say fortunately, I've had the opportunity to do mass testing. We're actually getting ready to do our second round of testing on our firefighters. So the mass testing that we do it with the serological test. We use the serological test as a screening tool. Because the PCR swab is the gold standard, what we do with the serological test, and we have one that we get results in 10 minutes. We did a mass drive-through testing, and we had 4 different sites. 3 sites where we had our north fire stations report to one of those stations. We set up a drive-through for them to come through. 1 at Central, 1 South, and then our main headquarters where we would get the bulk of our guys. At that main headquarters, we had as many as 4 lanes of traffic, right? Guys getting tested, and we were able to complete this in 6 days. And the only reason it was 6 days is because you're gonna get some guys that had that day off, right? Or they had battalion days. So we were able to run them through, and of course it was voluntary, right? So not everybody wanted to take the test, but we got most of our department that took the test, anybody that came up IgM, which means they're actively having the virus, those individuals was excluded. Those that were IgG, we monitored them. And as recently as today, we have our guys going back monthly, and they're going back to the individual station. And again, that's the beauty of having the nurses at our head. So the nurses are going to the individual stations, retesting the guys that have IgG, right? To see if they still have IgG. Because I personally having some issues with the serological test where I believe that the IgG that's showing up is not so much specific to COVID-19, right? Because on all the tests, they're showing some other COVID that it could potentially be. So there's the worry about how, you know, some of the false positive, and more importantly, the false negative that we're not catching. So that's the purpose for, again, I want to say 3.5 weeks later, we're going back and we're doing the mass testing. We're actually trying to get a different test. We still have more of these. So for the second round, we're going to be using what we have. But for the third round, we're looking to get a different brand that is FDA approved, the Celix brand that's supposed to be 95%. So our procurement is working on getting those for us. So our process with this is we're, you know, taking care of our guys is we're getting everybody tested. And it's not just specific to our firefighters. This includes dispatchers and non-sworn personnel. So you're talking about from the mechanic, you know, to anybody that's affiliated with Miami-Dade Fire Rescue. This has also been extended to, like I said before, police and corrections. Today we tested 54, most of them correction employees that are coming over to us testing as a testing site, which again, we've been approved by workers' comp, right? To be able to test the fire, not the fire department, but Miami-Dade employees. So we're not doing the screening process on them because workers' comp, they don't recognize the serological test. So because of that, we're using it as a screening tool. Exclude anybody that wasn't exposed to anybody so we could catch them that might be asymptomatic. Like the doctor said, we have as much as 30% that are asymptomatic that are carrying the virus. So we want to be able to catch those guys, exclude them, get them taken care of, and more importantly, get them excluded from also their family members. Because we're having firefighters that the wife's a nurse, wife's positive. That firefighter is now also excluded. And again, we have the resources to where we haven't lost that much of our workforce, so we're able to do this. So if a family member is positive, we're excluding that firefighter from work, just as if he was exposed to a patient. That employee is going to be excluded from work. He's going to be tested. He's going to be required to have 2 negative swabs before he can come back to work. And that's our health and safety monitoring. For also for our patients that are still positive, and we're fortunate that we only had one patient that was hospitalized that was serious. He's now recovered, and he's not back yet, but he's now produced 1 negative swab. So on his negative swab, he'll be able to be cleared. I'm not sure what your thoughts on this, Doc, but we have employees that are 30 days, 40 days that are still positive. So, you know, there is the concern for those guys, even though now they're asymptomatic. I'm more concerned, our team is more concerned with, how are these guys going to be 15 years down the road? Are these guys are going to be COPD guys? Can the guys pass their next physical? So, you know, these are the concerns that we're having, making sure that all the paperwork is squared away so they could be covered. We're hearing that it's going to be presumptive and they're going to be covered, but we have to be making sure that that's done. So there's guys that, some guys don't want to be excluded from work. So they might have some symptoms. They're like, listen, if I call Will, if I call any of these nurses, they're going to pull me from work. I don't want to lose my overtime. I don't want to be excluded. So we have to, those are the things that we have to educate our guys to say, listen, you got to think about not only you, your family, and also the other firefighters. So again, like I said, that educating part of it was very, very important. So the guys will know that, hey, listen, I got to do the right thing. You know, I got guys fighting with me saying, listen, man, I've been gone for 40 days, tested swab 4 times, still coming back positive, you know, and those are, you know, like somebody said earlier that one of the things that we know that the stuff keeps changing, and that's where the research comes in, where we've had to add these different signs and symptoms, and we have to evolve as this virus evolves. So that's what we're doing with health and safety, man. We're testing our guys, serologically using it as a screening tool. If they come up positive, we exclude them. They start getting nasal swab until we're able to get 2 negative swabs. Then they're able to return to work.
Excellent. Thank you, Captain Hall. Not only is your plan comprehensive, but it appears to be strategic and forward-thinking. So we thank you for that insight on health and safety of monitoring of our fire and EMS personnel, which we know very well without our fire and EMS personnel, no one is coming to help. So thank you. We're moving into the moderated question and answer session. And the first question is, what is this meeting aimed towards? And I will respond to that. This meeting is aimed towards working together, talking about the strengths, talking about and taking advantage of the opportunities, and building collaboration. And hopefully from the discussion here, the very informative and intellectually stimulating conversations we've had, hopefully we can derive some best practices and take all of this back to our respective agencies and work together to really fight this COVID-19 virus and strengthen what we're doing, enhance what we're doing, and in turn, protect our first responders, which in turn will help to protect our community and hopefully increase the health of our community and the people we serve. The next question is for Dr. Beyer. And it says, what impact has COVID-19 had on the Caribbean?
Right. So one of the major impacts that it's had on the Caribbean is that tourism for most of the countries is their #1 money earner. And without cruise ship visitors or airline visitors, there are a lot of people who now find themselves unemployed because their work, whether it's on the beach in terms of the jet ski guys, the boat guys, the people who work in the hotels, the people who work in those peripheral industry, restaurants or so, it's made even worse now by the curfew, where most of the restaurants are closed and they're only doing drive-through or curbside or whatever. There are a lot of people who are unemployed. And I mean, there's only so much you can go with unemployment. I mean, there's not a whole boatload of money there just waiting to pay everyone in terms of that before any revenue coming in. So that it has crippled the economy somewhat. I mean, they're now making, sequentially, they're actually trying now to open back, just like they are in other places, to open back up things gradually, trying to weigh that with a surge. Because if you open back up in a way that isn't correct, you probably, as you've seen in some places, have a surge of cases, and then you have to tighten it up again. I mean, everybody waits with bated breath to see, basically, as things are open up, what happens. Again, the airports can't keep being closed forever. So again, there will be folk, who will be coming to visit, whether for work, returning nationals, or otherwise. Again, that's a source of virus. Now, I know Will spoke about the serological tests and stuff, and that's a hot potato in terms of how basically whether you can use that for people traveling to say whether they can travel or not. Because as he rightly says, the tests are not very, very specific for COVID-19. You may be positive, but maybe because you've been exposed to another coronavirus, on the flip side of that, you may have a negative test and be in the incubation period, and then 3 days later, then basically you're positive and a risk to everybody again. So it's a very, very thin line you walk. So apart from the public health impact, it's having a major impact in terms of life as we know it.
Thank you, Dr. Beyer. The next question goes to Dr. Smith, and it states, recommendations for coping with psychological effects of COVID-19.
I think first, before I respond to that question, I want to say thanks to everyone for staying on with us. We still have 53 participants still engaged in this conversation, in this dialogue. So I want to say thank you very much for hanging in there with us. We're moving towards the end of the program, but I just want to say we appreciate you, and I'm watching the numbers, and I'm very happy that you're hanging with us, all right? So in response to that, psychological well-being of responders, very important, very important. But not only the responders, the family members of these responders and the nurses on the front line and the physicians on the front line, it's very important. As it relates to our operational framework, we have a health and safety committee, and we have a health and safety officer who normally is responsible for exposures and so on and so forth. But we also have what we call a peer support team. And with that peer support team is a group of peers, basically, who have gone through some training to kind of show, provide them some core competences of, identifying opportunities to help their fellow colleagues and other departments as well. So that is a very important element as it relates to fire brigade work, ambulance work, and also hospital work. But don't think that having a peer support committee is enough, because there are mental health professionals that need to be engaged in these processes. But also the fact that organizations need to recognize individuals who may be experiencing challenging issues with the COVID situation. Ones who may have just had a newborn at home. One who has an elderly family member that lives at home. I live with my mother. Okay, my mother lives with me. We live together. How about that? But the reality is she's in her 80s. She's elderly. Now, the idea really is that we need to think about a comprehensive approach to mental health as it relates to your specific organization and reflect on that after we finish tonight's meeting. What are you doing for your providers within your agency? Are you providing them the psychological support they need? Have you asked them how they're doing today? Have you looked at the type of calls, the frequency of exposures that they have potentially transported to the hospital? Those are important elements. And I think that as we move forward, we need to consider those elements as providers and managers and leaders within our respective agencies.
Thank you, Dr. Smith. One more question for you, sir. It says, how do Caribbean fire and EMT departments integrate geospatial data into their operations?
Great. I met a good colleague of mine at a conference, an ArcGIS conference. Actually, he became a very good colleague of mine. He's out of Antigua, he's a firefighter in Antigua. Very competent with the use of geospatial information software application. So we've been engaged for a number of months now. But it's interesting to see that the Caribbean actually is utilizing GIS information in terms of plotting positive cases and potentially actually even utilizing that information for decision-making processes. It may be produced or represented in a different way, or we may not have access to it based on our level of engagement with the local entities. But GIS technology is a technology that's been around. SEDEMA uses it for the natural disasters that occur, the hurricanes and so on and so forth. So it is well used. Now, the key is, how are we using it within EMS? How are we using it within the fire services? How are we using it to prevent death, prevent fires from occurring? How are we collecting information on buildings that are potentially put our firefighters and EMS responders at risk? Where are the exits? Where are the hydrants located? Are we able to see those hydrants and information on the maps, in the ambulances, or in the fire trucks for that matter, or in the command vehicles? So I think there's an opportunity in the Caribbean to actually implement GIS technology on a broader scale as it relates to pre-hospital care and emergency services response.
Here's another question directly related to GIS, which was just submitted. It says, apart from our Northern American colleagues, is anyone else actively using GIS in your COVID-19 response? So this goes out to our general panel. So anyone else?
Dr. Hanner, Dr. Albert Hanner, are you able to unmute your mic and respond to that regarding the Bahamas perspective in terms of using GIS?
Yes, the Bahamas is using the GIS. So, first of all, good night. Hello to everybody. It's nice to be a part of this, and I'm certainly enjoying it. Yes, the Bahamas is using the GIS, and there is a EOC that meets every day, and the chairperson decided that this would be very good to introduce so that we can see exactly where the cases are coming from. Initially, it seemed as if maybe more of the eastern side of New Providence, the island on which Nassau is located, seem to have had more of the cases, but now we are seeing more of a, I guess, a more generalized distribution over the island. And then our second city, Grand Bahama, there are some areas that we're seeing where the cases seem to be somewhat localized in clusters. And then our third island that has positive cases, definitely be seeing those hot spots. So it's helping to identify those areas. And as a matter of fact, it was just decided today in the EOC that that third island just need to be completely locked down, and just to bring some level of control. It's a key where that's very close to Florida, and there are sort of like private yachts and so on that may still be coming into that area. And so it is helping to map out the hotspots and also to make decisions with regard to further action, such as the one that I just mentioned.
Thank you very much.
Thank you.
Noel from Trinidad, are you on? All right.
Yeah, good night. Hi, I'm here.
Would you speak a little bit for about a minute or so regarding opportunities that you see that are realistic for GIS implementation?
Okay, well, good night, everyone. In terms of the long-term applications for GIS for both fire and EMS response, advances that ESRI and other companies that work with GIS software and geospatial software have made in the last 10 years or so, especially as it relates to mobile GIS and real-time GIS. They provide a very real opportunity for us in emergency response, in that not only can you access information that probably in the past would have been relegated to a filing cabinet somewhere in your headquarters or in some department, but you can access information in real time. You can relay information back to your command structure in real time to aid in decision making as situations progress and as they develop. Even going further, there's a lot of research going on now into indoor mapping and GIS within structures that would allow us to integrate the information that our fire prevention and our building inspection teams would have gathered over the years, integrate that in such a way that our responders or frontline workers would be able to use that. And this information is not static. It evolves, it changes as fast as you collect information in the field. And the real challenge with GIS is getting that baseline information in, building your foundation for your GIS, your geospatial response. And once you get that in place, everything else becomes updated as you go along. So for those of us who have dispatch centers, this information can link your dispatch center not only to your frontline workers, not only to your decision makers, but it allows them to tap into whatever sources of data that you have access to within your country. And for those of us in the Caribbean, I know that a lot of our governments are moving towards more open government structures where information is available across departments. Things are not as siloed as it used to be in the past. And if we can integrate GIS into our structures sooner rather than later, not just as something you pull out in the midst of a major emergency once in a while, but as something that you use on a daily basis, it makes our response more intelligent. So it's an opportunity to make fire and EMS response more intelligent. So we have more intelligent decision making across the board, whether it's responding to a brush fire, responding to a major earthquake or a major pandemic. That level of intelligence, that level of decision making ability remains there for us moving forward.
Thank you.
Thank you. Our next question is for Captain Hall and Dr. Beyer, and it states, what are the latest updates and infection control protocols?
I think we covered that, right? in the presentation. Will, do you have it? Captain Hall, you have something to add?
Yeah, one of the things I want to add, when we talk about these things that we're doing, we're providing them with our guys with the testing, we're providing them with all of this technology and all of this equipment. All of this stuff comes with some greater responsibility. So one of the things that can never be compromised is patient care. So it's a two-edged sword. So for our guys, we're able to do serological testing, mass testing. We're able to get our hazmat team involved. We're able to make sure that they're excluded if they're exposed. But on the other side, some of the things that we're now monitoring are our codes being worked like they were worked before, right? Our medical doctor, he's one of the few guys that I know that's still doing aerosolized treatment. And I was like, Doc, what are you doing? He's like, listen, it's still the first line drug, right? It's still the first line drug. We're allowing them to, don't do it inside the rescue truck, right? Do it outside. Somebody mentioned before, we actually have a chair where if the patient is able to, we'll allow the patient to come outside the home, have them sit outside, and if any treatment that would be considered high risk, right, we'll go ahead and give them, if we have to give them a nebulizer treatment, that treatment would be given there rather than given inside the back of the truck. So not because we're able to do some of these treatments that, and provide these equipment, the level of care and treatment of our patient still needs to be at that level, and that's one of the things that we're still able to do.
Excellent. We have one question here from Mark Boyce. It says, from a training perspective going forward, how should COVID-19 and any other emerging threat be approached as part of a future training module? So how can we be prepared and do some training going forward with COVID-19?
Yeah, I think Dr. Byers spoke a little bit, not a little bit about simulation, but he touched on it and the value of that. But in terms of distance education, there's opportunities now that have always actually existed, really, in terms of distance education. But the reality is, utilizing technology such as virtual reality, augmented reality, that are cloud-based applications can actually enhance education delivery model. So for example, you talk about an EMT program. How do you do an EMT program with this distancing issue or the social distancing concern and potential for people getting exposed, right? The reality is with the advent of WhatsApp, for example, you can do simulations and utilizing standardized patients or actually having one or two students go into the classroom, into the laboratory, where the third person is holding the camera and the facilitator is distant from them. So there are many opportunities for that, but I think where we're going to see some of the challenges would be in the fire service. How are you going to actually change your educational strategy to accommodate for some of these challenges in terms of distance, social distancing or professional distancing or whatever the case may be? Again, augmented virtual type reality platforms provide a great opportunity there. Certainly the psychomotor aspect of things will need to still occur, but I think there's opportunities there now that have always been there, but it's just a matter of how do you repurpose some of this application to actually fit your organizational needs.
Yeah, I'll speak to that very briefly. As an educator working for a state college, the challenge will be funding. And for example, we just returned to the lab today after 8 weeks of online instruction. The college finally cleared us and gave us permission to come back. And we have to finish out the lab hours of 60, 70 hours of the lab on the paramedic side, and then a lot more on the EMT side. And we are practicing social distancing. So the chairs are set out in the lab 6 feet apart, and we're following all the social distancing. But when it comes time to work on the mannequin, the students are wearing masks, which is being highly promoted. So they're working on the patients, on the mannequin, and after that we have to just decon the patient. So I think I appreciate what you're saying, Dr. Smith. Absolutely, simulation is a means to filling that void in the face of COVID. However, it's at a huge cost, and educational institutions, especially when they're being financed by the tax dollar, they have to look at that 2, 3, 4 times and ask, is it worth it? And what will taxpayers say? So it's sort of a double-edged sword. So our last question tonight, and then we'll have an open panel discussion. The last one is talking about hydrochloroquine. It says research has shown it is effective along with zinc early in management in COVID-19 cases. And Dr. Bayer, are you able to respond to that and give us from your medical perspective?
So I'll tell you, in terms of these studies, whether it's to do with the testing or the therapies, even the vaccine, there's been no randomized controlled studies on anything. So there's nothing that basically that you can hang your hat on at this point. A lot of people are doing a lot of things, you know, antigen testing, antibody testing. You know, they use the cocktail in terms of what they use for the HIV drugs. Even the president wants to use, you know what? Everybody's grabbing at something to see what is the next big thing. But the thing is, we haven't come to a point where, except the remdesivir, where we can say there's something that actually, in the majority of patients, proves benefit. The other thing is, on the flip side of that, because things have been going on for such a short period, we don't know what the side effects and long-term deleterious effects of these drugs are going to be. So we don't know 6 months down the road, 1 year down the road or so, we may cure COVID or do something for COVID, but then you have a high cancer rate or a high something. So we just don't know. So the studies basically haven't been conclusive on anything.
Excellent. I mean, 30 years from now, you'll be watching a television show and some lawyer will come on and say, hey, did you take hydrochloroquine? And are you blind now? So call me, we'll take care of it. So let's have as we talk about COVID and we look at some of the best practices, some of the knowledge that has been shared here tonight, and information, and certainly it has been an educational piece for all of us. How can we let's talk about a little bit about the future of EMS in the Caribbean. How do we go beyond this? How do we, as a region, as a CARICOM, how can we collectively work together, come together, and produce a product that can be standardized across the Caribbean in terms of EMS, training, education, Con Ed? So let's have an open discussion, and let's start it off with our Dr. Bayer, seeing that you are our medical director, and you are certainly an authority in terms of EMS education and providing medical direction. So if you could respond to that, please, and then we'll have Chief Dupe go after that.
Sure. Well, you know, certainly for us in the Caribbean, you know, when we got the EMT book or the paramedic book or so, everybody focused on the chapters to do with trauma and non-traumatic conditions, the heart-related conditions, the lung-related conditions. Not a lot of people read the chapter on weapons of mass destruction and hazmat and stuff, which are at the back of the book. And the reason that we probably didn't read them is because we probably said, well, you know, it probably isn't something that's applicable to the Caribbean. But here we are. So we have now a virus which has crippled the whole world. A few years ago, we dodged Ebola a little bit. We dodged the MERS, we dodged the SARS to some extent. H1N1 was before that, H3N1, the bird flu. So we've had these viruses coming at us in quick succession over the last few years. And probably when COVID is over, whether that's in 2021 and things stabilize or so, 2021, 2022, from what they project, there will be something else coming soon. So I think that we need to reorient our training towards this infectious disease, biological hazards type activity. And I think that one of the things, aside from the usual trauma, fracture, gunshot wound, stab wound, MI, you know, we need to put basically biological threats up there. Well, hazmat in general, but certainly biological threats up there, because we've been caught basically napping a little bit. Even in terms of the supplies, even for some of the larger countries who are running out of PPE and stuff like that. You know, most of us been caught napping a little bit with this one. So, I mean, it'll be now basically the trigger for us to consider infectious agents as something that we got to respect, and also use maybe a little bit better, a little bit more emphasis on it during the training and our collaborations.
Excellent, thank you, sir. Same question goes out to Chief Dupuy. The future, where do you see the future of EMS in the Caribbean?
Yeah, I think I got the better part of the question. I've been trying to follow. My signal is not very good. I hope you're hearing me clearly now.
We can hear you very clearly, sir.
Excellent. With regard to the future of EMS in the Caribbean, I think even if we did not have this reality of this virus and any other which is likely to come upon us, our data here in Dominica, I think the trends are very much the same in most of the Caribbean islands and probably across the world. What we have seen is that there is certainly a significant increase in the use of EMS services. For example, here on Dominica, our ambulances respond to about 95% of all our calls. So that is a seriously compelling piece of data. Often that data doesn't translate into the kind of financial allocations that go to providing the equipment that we need, the training, and the supplies, as Dr. Bayer was referring to just now. But clearly, just the advent of non-communicable diseases on our island and several of the islands in the Caribbean, that alone is a serious, it's a sufficient trigger to get us to really change gears with regard to EMS. For there to be a lot more emphasis. I think the relevance, as a matter of fact, of fire agencies or just agencies that are providing EMS services is going to increase significantly simply because of the prevalence of diseases such as diabetes, hypertension, and other non-communicable diseases. So clearly, we are going to see that kind of increase, and therefore, organizations must place a lot more emphasis, I think, on training. Their budgets must reflect what the data is saying. And I think it must direct us in terms of our policy direction. It must inform the recommendations that we make to central governments or whichever organization that we report to. And certainly the funds should be directed in the area where people are making greater demands on our organization.
Excellent. Thank you, sir. Same question to Chief Hutton.
All right, thank you, Mr. Chairman. Certainly, for EMS is very bright. Later down this year, we possibly will see us having 5 additional EMS sites in the fire brigade. We're presently looking at putting together a job description for a medical director. As we speak now, we take medical directorship from the Ministry of Health and Wellness. We're looking at standing on our own as it relates to EMS, like what obtaining the Jamaica Defense Force, the Correctional Service, and the Jamaica Constabulary Force. In terms of lessons learned from COVID-19, we would have seen some new norms, and I suspect that after COVID, there will be a lot of things that we would adopt in terms of training going forward. Right now, as a matter of fact, we had 85 recruits when we got our first confirmed case, and we had to pull the plug on that training. Now, right now, we are looking at exploring the option of how we go forward with training as this intake. Now, we're looking at incorporating a more robust ICT program going forward, because you will just have to adapt in order to manage this pandemic. Certainly, based on what I'm seeing, this pandemic will be with us for some time, and we can't put things on hold. The economy have to still pick up and continue to operate. So we see where it is necessary to not only improve on our training and the modality in how we deliver such training, but also putting certain plans in place. One, we never consider having a pandemic plan. That is something that we are currently working on, looking at some of the lessons learned to incorporate it into a plan going forward. So if the need arises when it's something else other than a pandemic, other than a COVID-19, we are able to quickly put the necessary things in place so that we can have our continuum of operations as a fire service.
Thank you. It would be remiss of me not to ask Chief Maynard for his input. You know, what are his thoughts on EMS in the Caribbean, where he sees the future of EMS in the Caribbean, in his thoughts?
If I could reframe the question, actually, would that be appropriate, Mr. Moderator?
Go ahead.
And I think this is another angle to the question. With the hurricane season approaching us, and it's forecasted to be an active one, and the advent of COVID-19 in our region, as the president of CAFC, how will this situation be factored into the deployment and team preparations to support the efforts of SEDEMA, sir?
Good night again to everyone. If I can just get on board, firstly, I see that EMS has a bright future going forward. I'm not sure that after COVID-19 that you will get the applicants that you were getting before as readily, because they recognize that it is not as easy a job as it used to be. Nevertheless, we actually have to relook at how we train our individuals, and you've mentioned a few of the things that you can do, the simulations and such like. And to Chief Horton, we also have about 23 persons to teach our recruits. And we have started using the online platform. We have just asked the Ministry of Health to approve some guidelines that we have put in place for the practical session in ensuring that they still observe the social distancing and make sure that we keep these officers safe for the time that they'll be there. But one of the things that we suggested is to test all of them, test the instructors. And I'm not sure if you have that facility, but we once we have the approval, we'll confine all of them for the period of the training. So they won't be able to go home for that period. Now, as relates to the issue of deployment during the hurricane season, what we have done, and I've also reached out to the RSS boss, Captain Sherman. We had a meeting in Captain Executive, and we have appointed or commissioned we call a COVID operational group, headed by, as I said before, Dr. Bayer. And that group is supposed to pull some ideas together from among the whole grouping of practitioners within the region, and not only that specific committee. And we're going to develop some guidelines that if we have to deploy any individuals during this period and going forward, because as Dr. Bayer said, we never know what it is tomorrow and going forward, that these guidelines will be there for the responders to use. But I'm almost sure that we will not be deploying anyone unless we have these guidelines in place, because if we're going to take people, husbands, children, mothers, wives, whoever, and deploy them, we have to do so in a safe manner. So CAFC will be shortly, and we're hoping that we can get some traction on this at least by the first week in June, when the hurricane season starts, that we'll have some guidelines to publish to all CAFC participation states and those who will be responding through the RSS. We also have just signed an MOU with, this is CAPC, with SEDIMA. And there too, I'm sure that once we have this mechanism in place, they too will be sharing some ideas of how we go forward. So basically, we don't have a CAPC plan in place, but we are actively pursuing one. Not CAPC, sorry, COVID plan in place. We are actively pursuing one to be put in place before we have the impact or any impact of the hurricane season 2020.
Thank you, Chief. Having been involved with CAPC over the past 6 or 7 years, and my role being the chair of EMS education, I've had the opportunity to travel and do EMT credentialing throughout the Caribbean. And based on what I've seen and my experience, I think we need to standardize the training, we need to standardize the education, and most importantly, and I will bet that Dr. Smith will agree with me, we need to have a Caribbean EMS agenda. And that will address all the elements, I believe there's 14 of them, that will address all the elements within EMS to have a robust system throughout the Caribbean. And that will it will eliminate the borders. Providers can go freely across the border. They can have reciprocity. And now that we have an agreement with SEDIMA, it certainly will facilitate the movement of EMS personnel. So I would like to see eventually a proliferation of this and bring the entire CARICOM together, where we go from Jamaica to Trinidad to Barbados to Antigua. We have the same level of training and we fall under one umbrella in EMS, and which will only improve what we do. It will also, in terms of our visitors and the citizens of those respective countries, it will definitely make us stronger. I'm going to ask Dr. Smith to give his perspective, and he will round out this session.
So, as most of you know, I'm very passionate about pre-hospital care and what's happening in the Caribbean and the importance of it. And I think that you speak to a very important point as it relates to an EMS agenda for the Caribbean. As I indicated earlier, the 1996 EMS Agenda of the Future, it was a framework that actually was utilized, different elements of it was utilized to establish EMS systems, not only in the US, but certainly UK and other areas. So I think it's a very fundamental thing that as a Caribbean nation, we should be establishing some document of sorts. You know, the EMS right now, 2020 agenda recently was released, but I think before we can even go there, we have to have that basic fundamental guideline or those elements of a system that will make it a more robust system, but also make it address scope of practice, address the medical care, address those different things from a legislative perspective, but also from an educational perspective in terms of credentialing pre-hospital providers. Firefighters do pretty good, I think, in the Caribbean, because I think fire. No matter which Caribbean country, fire is fire. You put water on fire. And the reality is the medical scope of practice should be similar, right? We would all agree, because at the end of the day, if somebody's bleeding from a traumatic injury, we need to take care of it, right? If somebody's having a heart attack, it's important to recognize it. Now, we may not have the tools and all these fancy things, but the basic fundamental things I think can be established if we create a process that has some kind of parameters that's set up in a way that it's actually transferable and is supported. The funding is there to support it. So at the end of the day, I think we have some ideas and how we can move forward with this, but we need the help of everyone here on this phone, on this Zoom meeting, I should say. Those of you on the phone, you're not showing your picture, but the reality is we need your help. We need you to engage with not only us, but engage with the people that you know are connected, that who can influence decision. The chief medical officers, I think they meet annually. I don't know if they're going to meet this year in person, but it's probably going to be virtual. We need that endorsement. We need that support, and we need that comprehensive approach to EMS and pre-hospital care across the Caribbean. So I'm very passionate about that, and I'm very passionate about the attitudes of the stakeholders. I think that is the part that we need to really understand, that there's affect, how you feel, and what you believe, and how it influences your behavior. So those three things should be in alignment. There should be alignment within those three, regardless of what part of the fence you're on as a stakeholder, whether you're a non-clinician or whether you're a politician. It should be, your attitude towards pre-hospital care should probably be in alignment. I'll close with that.
Thank you, Thank you, Dr. Smith. A lot of passion. I can feel it, sir. We're going to end with, we'll end our forum here by asking, we'll start with Captain Will, and as he presents his last comments to.
Mr. Moderator, can I say something quick before you get to your closing sentiments?
Yes, sir. Yes, sir.
The CAFC is planning what we call a virtual meeting for the heads, or a virtual conference, I think sometime in June. And July, I think it will be. And what I am thinking, that we should actually add the EMS on the agenda as a significant part of the agenda, because what we are seeing now, and as we've been pushing the EMS part of CAFC for a while, I think that we need to place on the agenda to see how far we can push it, and also to gather some momentum from the discussions that we would have had in Barbados during the conference. I think that is critical, because I don't think since then we actually generated any momentum on those discussions that we would have had then, and they were well received by the doctors from the University of West Indies, Dr. Watson and his group. So I believe that we should put that on there, and you and the registry team will get a chance to put forward some citing, but we will discuss that offline another time. But I felt it was necessary to put that in there, put it in now, that we would want to have the EMS on that agenda.
Thank you, sir. As we move towards the end, we'll invite any of our participants, if they would like to make any comments.
Hello. Yes, I think I'm unmuted. This is Doreen Gumsvines. I wanted to say I think that this has been very informative. And Chief Smith, what you said about the Caribbean EMS agenda, I think one of the things that everyone on this this meeting should keep in mind is that there's a lot of information that we could use as foundational. We do not have to reinvent the wheel. The EMS agenda of the future is a very, very, very important document. There are also different documents that we can use and tailor it to the need of the Caribbean. And I think it's a very easy thing to do, because that framework is there. It's there, and we just have to tighten it up. And I'm excited about that opportunity to be able to have it so that we can have reciprocity between each Caribbean island. Because I'm passionate. I see Chief McLean and Chief Penn on there, who I'm very passionate with those. I've had a very close relationship with those 5 officers in EMS, and also in St. Kitts, Nevis, and Anguilla. And I'm excited about the number of people that's on here, the talent and the possibilities of what we can do. So I'm all in, and I just wanted to add that those documents that are out there, all we need to do is fine tune those documents. The education is the framework is there.
Thank you, Doreen. Anyone else?
Dr. Warren, I would like to chip in, probably exit before you bring this meeting to a close, this discussion, but I'd like to chip in now. I really want to acknowledge Chief Richards. Chief Richards has been our president, forever. Am I correct, Chief Richards? And
yes, sir.
He has been one of the champions also of EMS in the Caribbean. Drop on this meeting without acknowledging him. So Chief Richards, thank you for your fantastic leadership and for all that you have put into EMS in the Caribbean. I also want to acknowledge Chief Smith for putting this together and for the demonstrated passion. That word came up a few times tonight, I know, but sometimes you need to say the same word over and over if it applies. Of course, Dr. Bai, you've been with us at CAFC and you've demonstrated your commitment and willingness to continue to work with us, hard-headed fire chiefs of the Caribbean. Yourself, Mr. Chair, I really have appreciated you over the years. A little bit more quiet than Chief Smith, the Jamaican, but certainly very deep, very profound. And I just want to spend my moments here just saying thank you to you guys, because what I have seen myself, I mean, I came in on the block as a tender fire chief, and over time I saw a sort of conflict between fire and EMS, one which for me, there was no conflict, but I saw individuals trying to guard their turf, not probably wanting to be open to change, but there are some things that you can stand in the way and there are some things you just can't. And I think EMS is ready rolling, and we who are a little bit more stubborn or just plain old difficult should come on board. After all, we are all in the business of serving lives. That's our fundamental responsibility. So whether it's EMS, whether it is fire or any other discipline, I think we should all come on board and do our part. So I just really wanted to give those kudos out and to say that it was truly a pleasure for me to be here. This is really not the beginning, but it is part of the journey of what is happening in EMS. And I feel really privileged to be part of this. And I want to say to those of us on the panel and even to the rest who are on board here, let us continue to do the best that we can so that we can have the kind of impact that we, I think, desire for the people that we serve. Well done tonight. Fantastic job, Chief Smith. Keep it up. And let me just say good night to everybody. I must go to attend a few things now, but thank you for allowing me these viewers. Good night, everybody.
Wrap-up session.
Dr. Warren, Jermaine
Yes,
McFarlane, can you hear me?
I can, sir.
Okay, good night, everyone. Jermaine McFarlane. Just great forum. Once again, you could see the cohesiveness, and it's always good when we could talk and get together and pretty much explain our best practices, what everyone is doing. Obviously, everyone operate differently, but when you hear someone practices, you could always retrofit your agency and do what you need to do to respond to the emergency. But as you talk about the common agenda for the EMS, obviously that's something that's definitely need to be sought after. It's definitely attainable. If you guys are familiar with some of the South American countries and some of the Central American companies, I went to Ecuador a few years ago, and one of the things they were working on is to create a common protocol for Central America and some of the countries in South America who utilize the Red Cross as their main hub for the EMS. And I think at the time the book or the protocol was completed. So that's something definitely that we could attain in the Caribbean, but just to do things like this and continue to work at it. But I want to go back real quick to the COVID-19 and some of the things that all of us need to look at is really the effect and after effect of this COVID-19. We talk about the psychological impact, but even for first responders that were affected or infected, you might have a lot of first responders who can't get back in the field. What they've realized, a lot of these folks are having permanent lung damage. They're having a lot of permanent tissue that are damaged. So, a lot of them can't get back to a job of firefighting. So that's something also, we need to look at workers probably can't get back to normalcy. Obviously, drug abuse went up to arson. A lot of small businesses that are not planning on going back into business or can't go back into business. As a fire service, we need to look at those things. domestic violence. And also, one of the things that the agencies in the States have noticed, I'm not sure about the Caribbean, is looking at the DOAs. Obviously, the call volume, like what Chief Smith stated, went down about 20 to 30%, and if you look at the years prior in EMS, the call volume was always consistent. So where are those patients going? So that's something that, we need to look at, after the fact. Probably the good thing that that's going to come out of this, if it's a positive thing, is the pregnancy with everyone staying at home. They're anticipating the next few months, you may have a lot of babies that are being born. Also, as far as this, we also need to look at the reopening of, countries or city. Or are you going to reopen your city, especially a lot of these Caribbean nations where your main revenue is tourism, Or are you going to mandate the PPE, social distancing? That's going to be a challenge, for you, especially when you open up and you have visitors or tourists, that are coming back into your company, into your country. Procurement is going to be a big issue. Also, you got to look at the fact that when countries or cities open up back, they're going to be buying a lot of these PPEs, because a lot of them are going to be pretty much enforcing the same policies or protocols that we are doing. Their employees are going to be wearing PPE. So already, if there's a shortage, there's going to be a bigger shortage. So you probably want to start procure a lot of PPE for now. And also, real quick, looking next month is hurricane season. So you also got to prepare for that and keep COVID-19 in mind. You may have to do some modified EOC, FOC. Your shelters, are you going to still have the same volume with social distancing? So those are some of the things that you need to start look at as far as a country, city, as far as reopening and the hurricane season pending. Or are we going to still procure adequate PPE and maintain social distancing, and then look at the effect of this COVID-19 on our citizens? That chiming in.
Say a few comments. You're like the godfather here.
Chief Richards, we got a minute. We're losing people.
He needs to be unmuted.
Informative, and I wish to thank the organizers of this forum. I do know that we have some heavy hitters on board. And let me also thank Dr. Bayer for a great presentation on the medical side. It was really, really beautiful. And of course, Doreen, I want to second the motion with regards to the EMS agenda for the future. I believe there is a draft document around somewhere that we could probably resurrect from the hard drive on the computer somewhere, and maybe do some work on that and create something that would be applicable to the Caribbean. And of course, let me thank Chief Dupuy for those kind words. It was much appreciated. But I am available, and just call on me. I'll be 100%, 120% participant.
Thank you, Chief.
Thanks, Chief. Anyone else? Okay, we'll now move to Captain Woolhall for closing comments. And could you also mention something about the mask being reused and being cleaned and sterilized in your closing comments, please?
There's two companies that have received grants to start reusing masks. I've spoken to the rep for one of the companies, and I wasn't impressed with what I was hearing. So based on, I won't say it's the curve going down, that's not something that we're looking to purchase anymore. And they got the grant funds, and the research, what they were showing me wasn't consistent with what they were saying. So it wasn't something that was feasible for our department. So we didn't go in that direction. Again, I want to thank you guys for allowing me to be a part of this panel. I appreciate it, and learned a lot. And 42 participants that are here. I hope they enjoyed it also, and we'll be back with part 2.
Thank you, Captain Well. I will ask Chief Houghton to say a few closing comments, please.
Well, I would like to thank the organizers for the invite to participate in this forum. I would have learned a lot, and certainly I hope from what we would have been doing here in Jamaica, some of the things can be adopted in our other Caribbean countries. I look forward to continue working with CAFC here, available for you to utilize in any way for the improvement of the fire service in the Caribbean. Thank you.
Thank you, Chief.
Mr. Moderator, real quick, Jermaine McFarland again. Can you hear me? I was driving, so my.
Yes, Chief.
Yeah, as you talk about mask, I don't know for you, you guys, but here in the States, the masks, especially the N95s, are really expensive. So a consideration, what we did was we used the 3M respirators, the AF face ones. We used those on every calls, and those could give us, I'll say, at least approximately about 6 months of usage, because when we calculate the price of an N95, which is averaging about $4, and looking at our burn rate, we went that route. So we're using the AF face mask. We issued everyone an AF face mask respirator, which the price is about $27 US, and it has multiple usage. And what we did for evasive procedures, we looked at it, and like what Chief Smith mentioned, that instead of intubation, using the supraglottic airway in terms of not aerolizing too much. So obviously we looked at those trauma patients, especially those head injury patients that are going to require some type of intubation. So what we did also, we purchased the full face mask, and those are 100% protected and 100% particulate protected. So just the way we run, we went, and utilizing those, we could do evasive procedures, additional PPE, like obviously gloves and gowns. So that's the way we run as far as masks and respirators.
Thank you, Chief. Our star presenter this evening, Dr. Meyer.
Well, okay, so I am happy. I know Dean, this is Dean and your idea and stuff, and it came to me, and obviously it's a no-brainer. And it's very enlightening to hear folks from all corners of the Caribbean, and obviously you guys who are part of the diaspora in terms of the United States, but you have your tentacles originating from the Caribbean. So it's heartening to hear all of us to talk shop. And I'm certainly, I know we're talking COVID now, but I'm here thinking that maybe we should look to have some of these forums and periodically, whether it is trauma or some other area of EMS, that we can talk shop in terms of share ideas. So I'm thinking we should look to make this there in terms of some level of on a schedule, so to speak. But we can talk about that there offline. But I'm happy to be a part of it. And thank you, Mr. Moderator.
Thank you, Dr. Barr. I agree about making it more of a regular presentation, maybe quarterly or however we work it out.
2 weeks.
Well, since you're on, Dr. Smith, would you like to say a few closing words, please?
I just want to say thank everybody for hanging in here with us and really being a part of this. I want to thank you all for buying into the idea that we do something like this to give back to our Caribbean brothers and sisters, because it's very important that we share what we know, and hopefully we can improve and influence decisions and operational practices. So just thank you very much. I know it's been a long evening, but you know what? Love.
I agree. Chief Maynard, sir.
I think he's good. He's tired.
Is he eating?
I think we're good.
Chief Maynard.
I'll say good night to everyone. Thank you very much for hanging out with us, and we really appreciate it.
I declare the COVID-19 Caribbean EMS Forum closed. Thank you very much.
Thank
and
you.
We look forward to talking to you soon.
We'll send a survey to all the attendees. Thank you very much again. Bye-bye.
Bye-bye.